Today we are going to have another topic in clinical orthopedics. The topic is going to be supraspinatus tendon injury. It is one of the important muscle in the rotator cuff muscles. So there are four muscles actually. In that, supraspinatus is an important muscle. Supraspinatus tendon. Basically, this muscle is originating from the supraspinatus fossa of the scapula and getting inserted at the greater tuberosity of the humerus. That too, the superior part of the greater tuberosity. So, what happens when there is a movement taking place in the shoulder joint, abduction? This is the first tendon to be going under the acromion process, between the greater tuberosity and the acromion process, out of all the other rotator cuff tendons. If there is any problem to this tendon, and this could eventually result compression there, impingement under the acromion process, between the greater tuberosity and acromion process. So basically this will result in loss of abduction movement. We all know supraspinatus tendon is the initial abductor muscle, the muscle that causes the initial abduction of the shoulder. Okay. So these are the clinical importance and anatomical importance of this particular muscle and the tendon. Coming to who are more commonly affected with this supraspinatus tendon injuries. Most commonly is the old age people, anybody who are aged more than 60. They are very much prone to get injury to the supraspinatus tendon because of the degenerative process taking place in the tendon. Apart from that, active young adult, mostly sports people, because of the sports nature, the fall on outstretched hand and other things, repeated use of the shoulder joint, the tendon can be strained more. So coming to the mechanism, most common mechanism is fall on the outstretched hand. And the second one is while lifting heavy weight and sudden slippage of the weight. So what happens? A sudden movement, jerk movement takes place in the shoulder joint that affects the supraspinatus tendon. These are two important mechanisms that are identified with this particular injury. And what are the clinical features? Clinical features, most common is restriction of shoulder abduction and pain at the tip of the shoulder. Tip of the shoulder pain will be there, and of course tenderness will be there. And restriction of shoulder abduction, especially at the 90-degree range, at the mid range of abduction will be more painful. Suppose if the tendon is partially, it is only when the tendon is partially affected, we can see the painful lock syndrome. That is, while abducting the shoulder, the middle range of the shoulder abduction would be painful. Suppose if the tendon is completely cut, then there will be no shoulder abduction. In some cases, painful arc will be painless. However, the patient will have pain. When we do the painful arc, it is painless. When you do passively, it is still painless. So this could be due to injury to the muscle and tendon junction, musculotendinous junction of the supraspinatus muscle, not at the tendon. So that might be, we might miss this particular condition if we are completely dependent on painful lock syndrome. So painful lock syndrome is mostly positive only when there is a injury to the tendon or inflammation in the tendon. Supraspinatus tendinitis also can cause painful lock syndrome. Syriac is the famous uh, clinician identifies painful lock syndrome is found to be positive in 5 conditions. Number 1, greater tuberosity fracture. Number 2, supraspinatus tendon injury. Number 3, supraspinatus tendon inflammation. We call it supraspinatus tendinitis. And number 4, supraspinatus tendon calcium deposition. Number 5, subacromial bursitis. A bursub below the subacromial, below the acromion process. That bursitis also can cause painful lock syndrome. So painful lock syndrome is not a very definite test to identify the supraspinatus tendon injury. So we also have another test to identify a clinical test to identify the any problem to the supraspinatus tendon and the muscle, which is the MT-CAN test. Okay, asking the patient to do the 60-degree flexion and 90-degree abduction and completely internally rotating the hand. And okay, so in this position, this is the position called MT-CAN position. So in this position, any shoulder abduction is resisted, and that will give pain to the supraspinatus muscle. Okay, so if the pain is very severe and remarkable, and it indicates there is a problem to the tendon of the supraspinatus muscle and the tendon. Okay, coming to the management part. Clinically, this particular supraspinatus tendon is mostly repaired. If the person is a young adult, the tendon repairing procedure will be done, whether it's a partial or full tear. If the patient is an old age person, then mostly surgery is avoided, because in those cases, old age cases, when the surgery is attempted, there is a huge complication in the future in terms of shoulder joint stiffness and secondary shoulder osteoarthritis, glenohumeral osteoarthritis, and subacromial, acromion related joints also will be affected. So all the accessory joints also will become very stiff. So because of this reason, in old age patients, the surgical repairing is avoided. Okay, so after the initial management, conservative management or surgery, the patient will be immobilized in a very peculiar position, which is shoulder joint 90-degree abduction and 60-degree flexion and 45-degree internal rotation. In this position, the patient will be positioned so that the joint gets complete healing. Okay, shoulder joint 90-degree abduction, 60-degree flexion and 45-degree lateral rotation. Not internal rotation, it's a lateral rotation. So in that position, the muscle tendon is completely, it is kept at the ideal length so that the healing process takes place very well. Normally 3 weeks. 3 weeks is the time required for any tendon injury to repair itself, because up to 21 days, the collagen will deposit at the repaired area or the injured area, and after the 21 days, what happens? The collagen gets reshaping. Rearrangement of the fibers will be taking place. That is the right time to initiate to remove the mobilizations, to remove the immobilizations and start the mobilizations. Active movements can be included at that time. So that is the protocol for the conservative and surgical management of the supraspinatus tendon. And coming to the complications, the most common complication is shoulder joint stiffness and secondary osteoarthritis of the glenohumeral joint. And also, trick movements is another common problem with this particular muscle. If the muscle does not get the appropriate strength, what happens? The patient will try to do the abduction with the help of shoulder blade rotation. He will do the rotation of the shoulder blade with the help of the deltoid muscle and do the abduction. Instead of using the supraspinatus muscle to do the abduction, he will be using the deltoid muscle to do the abduction. This is called tricky movement, and sometimes this is very strongly registered in the patient's mind and the physical pattern, movement pattern, and very difficult to eradicate it. So it is very important to start the active mobility exercises immediately once the immobilizations are removed, and the muscle should be stimulated, re-educated, strengthened gradually, and the transverse friction massage can be applied on the fibers of the tendon to realign the collagen depositions, and also shoulder joint mobilization exercises. All these things are very, very important. Icing, to reduce pain, icing, ultrasound treatments to accelerate the healing process, to strengthen further the tendon. All these things would be very much useful. So this is what about the overall management for the conservative and overall management for the supraspinatus tendinitis. So students, please listen to this video lecture a few times, and once you have watched, the fourth year students who are having PT ortho, try to identify the plan of PT management for this supraspinatus tendon. Okay, so thank you very much and have a nice day.